Morning, everyone. Welcome. Thank you for coming. Today we have a special Grand Rounds. Today's Grand Rounds are co-sponsored by the Department of Medicine and the Center for Research of the Management of Sleep Disturbance within the School of Nursing. So today we have Dr. Punjabi. Dr. Punjabi finished his undergrad education at Northwestern University, his medical degree from the University of Chicago, and then his internal medicine residency, pulmonary critical care fellowship, and sleep medicine training, all at the Johns Hopkins University. Dr. Punjabi subsequently completed his PhD in clinical investigation at the Johns Hopkins Bloomberg School of Public Health. His current research interests are in epidemiology and obstructive sleep apnea and how these affect insulin resistance, diabetes, and cardiovascular disease. He's widely published, including several journals of circulation, sleep epidemiology, American Journal of Respiratory and Critical Care Medicine, and Nature Genetics. Dr. Punjabi is now Professor of Medicine and Epidemiology in the Division of Pulmonary and Critical Care at Hopkins. He is also a diplomat of the American Board of Sleep Medicine and fellow of both the American Academy of Sleep Medicine and the American College of Chest Physicians. So please join me in welcoming Dr. Punjabi today as he gives cardiovascular and metabolic implications of obstructive sleep apnea.
Thank you very much for that introduction. Boy, that sounds like I don't have a life. I really don't. Actually, the truth is I don't have a life. Thank you for having me. I want to extend my sincere thanks to the folks in the Center for Sleep Research at the School of Nursing here, Mike Bidiella in particular, who I've known for almost now a decade plus. For those that don't know me, I actually interviewed for a position here in pulmonary many years ago. And it's an interesting homecoming in some ways. In 2004, I think it was, I came out here to look for a position and it was closed. I almost put an offer in the house that the pulmonary folks didn't know about. Anyway, thanks for having me. I've unfortunately taken on a very difficult task of covering the cardiovascular and metabolic implications of sleep apnea. The cardiovascular implications could take a full day. The metabolic implications could take a full day. So what I've really tried to do here for a medical audience is to give you an overview of what we've learned in the last sort of decade or so with research. Now, what's really interesting about sleep apnea research is one of the largest epidemiological studies was actually housed at UW many years ago, and I'm going to show you some of that data. And it is interesting that it's somewhat of a homecoming for this very large study called the Sleep Heart Health Study. Now, before I get started, just a quick disclosure. I have received support with regards to equipment, CPAP machines, for several NIH studies that I do. The sponsors have been Respironics and ResMed, and I also received grant support from ResMed for a multi-center clinical trial of CPAP therapy in obstructive sleep apnea for diabetes. But nothing I say today will be related to any of that, so it's completely sort of independent. I wanted to give you a whirlwind tour of what sleep apnea is, and I'm going to get this started. Sleep apnea is now getting very common. Listen to this. So it's permeating into our comedy world. She has very typical physiognomy of sleep apnea, central obesity. I mean, she does. It's a very, and she's good with that. She's very good with that. Very typical spouse complaints. Yeah? But, so, it's very interesting that it's got to that far because you see this in the comedy world. I've got many such things. I've got another one that's about a younger man who talks about the same thing. Here's what I want to do with just a general outline. Again, this is quite a bit of history of sleep apnea. Almost a decade has gone by where we've tried to look at what cardiovascular and metabolic implications, and I really want to give you a 30,000-mile view of this evidence. Let's start with some definitions. What do we mean by sleep apnea? What are the issues? How do we define it? And obviously, how do we diagnose it? We diagnose it based on a polysomnogram. A polysomnogram is a test that's done in a sleep laboratory. And this is a typical tracing, a very complicated set of physiologic channel signals that come out of a typical tracing when you refer somebody to the sleep laboratory. But it's relatively straightforward. We monitor the EEGs. We monitor the electrocardiogram. We monitor oxygen saturation, and you can already see the repetitive dips in this individual. We monitor airflow via a different set of tools. We use a pressure transducer, we use a thermal device, and we also measure thoracic and abdominal excursion. And what you can see in this sort of even far away view of this thing is that you got repetitive desaturations in this individual, periods of no airflow. But what's interesting is if you look very closely to the thorax and abdominal movements, you see paradoxical breathing. It may not be obvious from far, but the folks nearby can actually see that there will be sort of an in-phase motion here, but out of phase. Very classic for paradoxical breathing that you know with obstructive airway. You get recurrent arousals in these individuals, and it's really the recurrent arousals in combination with the repetitive desaturations, which are due to this airway collapse, that lead to some of these endpoints that we've been interested in for the last decade or so, particularly with cardiovascular outcomes such as hypertension, myocardial infarction, heart failure, stroke, and maybe even diabetes. We define sleep apnea based on a metric. It's a very simple metric. It's called the apnea-hypopnea index. I introduced it because I'll be using this throughout. And what it is, it's the number of apneas, and these are defined by breathing pauses, complete cessation in airflow. Literally, there's no airflow. And hypopneas, these are decreases in airflow that occur per hour of sleep. So it's a very simple counting metric. We have the number of these and the number of these. Both of these combined are called disordered breathing events, and we have various measures of how we go about defining hypopneas. I won't belabor that. There's some controversy in our own literature how best to define these. But for our discussion, we'll just say the apnea-hypopnea index is used to define sleep apnea. And normally, the apnea-hypopnea index, a normal threshold is about 5 events per hour. By the way, sleep folks are very, very simple. We know how to count. We do a counting process. What about pathophysiological? Why would something like this that has recurrent arousals, recurrent hypoxemia be associated with cardiovascular endpoints? I want to sort of put away a myth that sleep apnea is very common in that overweight middle-aged woman that you saw. Here's a young man, and here's a young man. I'll turn the sound up. This is a video made by his mother. And if you look very closely, and I'll go through this, for some of you who have watches on, you may want to time him how long his breathing pauses occur. By the way, he's completely apneic at this point. So mom is filming this video, and you can see amazing interthoracic swings. He actually gets retractions. You can really see the amount of negative pressure he's generating with each apneic episode. And again, there's no airflow at all. I kind of challenge any one of you to hold your breath as long as he does. Again, no breathing whatsoever. So that's the first breath that he's taken. Anybody tell me why this fellow would have sleep apnea? He doesn't have any of the features of being overweight, obese. You know, he's got some very typical features for Asians, particularly, Asians that have sleep apnea. You see that? He's got a little bit of retrognathia and micrognathia. So that's his risk factor. He has very prolonged pauses in breathing. He started another one right now. He's completely apneic. And here you can see that profile. He has that retrognathia, and that's most likely his risk factor. Obviously, very thin male, none of the risk factors, and he's apneic. So the physiology of this is obviously clear. The upper airway collapses during sleep. He's still apneic. And the collapsibility of the airway leads to no flow or absent flow, like in this young male, and recurrent hypoxemia. And again, he's still apneic. And he goes on for about a minute or so. His periods of apnea are really prolonged. This is not uncommon. This is very common, obviously, in our Caucasian samples that we see in the Western world, but also, so that's it. So about a minute to a minute and a half is he's apneic. I wanted to show that because I think it really makes the point that apnea is not just a disease of the overweight middle-aged male. It can affect young folks, it can affect women. Really, it hits everybody. Now, why would something like apnea lead to cardiovascular outcomes? What I've done here is a cartoon, and I want to walk you through this cartoon. This cartoon showed you that there is paradoxical breathing because the airway has collapsed. With that paradoxical breathing, you obviously get a decrease in oxygen saturation. And if you monitor blood pressure during the course of the night, you get this increase in blood pressure, particularly towards the tail end of the event. That event is then terminated by an arousal, as shown in this cartoon with an EEG increase in firing. And it is thought that the hypoxemia, the reoxygenation, the hypercapnia, the pleural pressure swings, and the recurrent arousals in these folks leads to a variety of outcomes, or a variety of intermediate mechanisms that may lead to downstream events. There is no doubt that hypoxemia and arousals lead to sympathetic activation. There's evidence that it leads to endothelial dysfunction, oxidative stress, alterations in some of the inflammatory pathways, abnormalities in coagulation. An area of my particular interest has been insulin resistance for the last decade, and we think there may be an effect of hypoxemia and arousals on mediating insulin resistance, and possibly also leptin resistance. And it is thought that when you bring all of these mechanisms together, and no one particular one is very more important than the other, you can lead to heart failure, high blood pressure, arrhythmias, ischemia, myocardial ischemia, and cerebrovascular disease. So it's really this sort of compilation of abnormalities that are thought to be mediated by hypoxemia. If someone had to ask me what is the one critical thing that these folks, I am becoming more and more convinced that sympathetic activation seems to be a very central source of the downstream events. These people are really, really sort of revved up sympathetically. Now let me show you sort of that 30,000-mile view. What have we learned over the last decade or so regarding sleep apnea and cardiovascular disease? I'll talk to you a little bit about prevalent and incident hypertension, something that I think is very important for a general medical crew. I'll talk about a little bit about prevalent and incident coronary artery disease and heart failure. Show you a little bit of the data on links with sleep apnea and arrhythmias, and in particular atrial fibrillation. Talk to you about sudden cardiac death, a little bit on stroke, and then finish up with some overview of what are the metabolic implications of recurrent hypoxemia and arousals in these individuals. Now, there are numerous studies that have really taught us a lot over the last decade or 2 decades about what the implications of sleep apnea are. Sleep Art Health Study is one of the larger studies that's ongoing now for about 20 years. And it's interesting, the coordinating for the Sleep Art Health Study was in fact at the University of Washington from 1994 through 1999. In 1999, the Sleep Art Health Study moved its center to Johns Hopkins. And in fact, that was one of the reasons I didn't move to UW, because I would have chased that study around. Wisconsin Sleep Cohort Study is another study that's about 25 years old now, roughly, has shown us quite a bit on incident disease. There are other epidemiological studies, the Penn Sleep Cohort Study. There's a Spanish consortium of multiple sleep centers that are doing a great amount of, putting in a lot of effort looking at clinical settings and seeing whether individuals with sleep apnea are predisposed to a higher risk of hypertension, a variety of different outcomes, and numerous clinical trials. What I've done here is sampled a little bit for you from all of these things, just to provide that sort of bird's eye view of the literature in this area. I wanted to pick on the Sleep Art Health Study for 2 reasons. One, I'm involved in it. I know some of the faculty here are involved in it. Vishesh Kapoor has been part of it when this study was here. The study really was from UW. It was a coordinating center here. What was this study? So this is an epidemiological study that started as a prospective cohort design. It was multi-center. And what the NHLBI did at that time is something very unique. There were all these studies ongoing in the United States, the Framingham study, the Atherosclerosis Research and Community Study. There are numerous epidemiological studies that were ongoing. And what the NHLBI did is said, okay, while they're doing all these outcomes, such as echoes, hypertension risk, looking at all these different outcomes, why not add on sleep to these ongoing studies? And what we aimed for at that time is to really get a nice wide geographic and ethnic representation of middle-aged and older adults. One of the key things I want to emphasize about this study, this is not a clinical sample. That's very critical to underline. This is a community-based sample of middle-aged and older adults that were sampled from epidemiological studies that were ongoing on cardiovascular and respiratory disease. And again, this is a sample of middle-aged and older adults. This is an important issue, this concept of older adults, because there's some survival bias issues that come into play, because these are cohort studies that have been ongoing for almost 2 to 3 decades, and sleep becomes part of it in about mid-1994. I apologize for not putting a dot here for Seattle. I didn't mean that in any way, but this is a pro forma map that I show. But there should be a dot here at Seattle that says, originally the study was here. And I still remember many of the folks. I remember coming out here at 4 of those meetings. these are the actual field sites that the subjects are at. I'm being fair in some ways. Hopkins, well, the coordinating center, is not on the dot, so I'm being fair and equal. I've not included my home institution either. We in Baltimore follow 1,184 subjects. The Framingham cohort contributed 1,000. And all of these different sites, in some fashion, are associated with these other studies that have contributed the numbers that you see here. In 1994, we started with this cohort. The sample amounted to about 6,444. Coordinating center was at Seattle, moved to Hopkins. I should have one more. The Cleveland site was the reading center for our sleep studies. We had one central center where we looked at every study in a standardized sleep study in a standardized fashion. The other thing I should mention is that for the first time ever in the history of sleep medicine, a large epidemiological effort was undertaken with home polysomnography. And this was full montage polysomnography. What that means is instead of having them to come to the sleep laboratory to do their sleep test, this study really reached out and said, let's go to the home, primary matter of convenience, and to really get a good representation of what sleep and breathing abnormalities look like. So again, a very huge effort by numerous investigators, and obviously a large sample size of a community cohort. And this is what it looked like. In 1994, the study was funded. It took about 2 years to get the baseline polysomnography. The PSG is a nomenclature that we use to define polysomnography. 6,000 folks were enrolled. Every year, there's outcome surveillance. A follow-up, we went back to the cohort in 2002. It took us 2 years to get as many as we could that were alive. 3,000 or more were alive. 3,000 allowed us to do sleep studies. We've continued to survey them every year, and officially the funding for the study ended in about starting at 2012. So I'm going to show you some of the data that's recently published from this very huge undertaking of almost 20 years at this point. So let's talk a little bit about what we learned from that and other studies. What I've done is embedded the other studies into this study to show you what we know about sleep apnea and hypertension. And here what I want to show you is not just prevalent hypertension, but also incident hypertension, obviously a more important issue. For the sleep apnea study, and as for many epidemiological studies, hypertension was defined as the presence of blood pressure systolic 140, 90, or diastolic, or being on current treatment for hypertension. Keep in mind, the first couple of slides that I'll show you will be cross-sectional analysis, which basically says, is there an association between the presence of sleep apnea and prevalent hypertension? Then I'll show you data on what happens if you don't have hypertension today and you have sleep apnea today, but the sleep apnea is left untreated, and what happens over a 10 to 15 year period of untreated sleep apnea from the standpoint of the development of hypertension or incident hypertension. Prevalent cardiovascular disease and also incident cardiovascular disease was defined as follows: as the presence of any of these things, infarct, angina, angioplasty, bypass surgery, heart failure, and stroke. Again, that's the prevalent definition. The incident definition is very similar. Development of these things in the absence of them at baseline, or a recurrent event if you had baseline prevalent cardiovascular disease. So that's sort of the framework of definitions. So this is a paper that's almost a decade old now from this study that looked at the sleep apnea and prevalent hypertension. That's very, very important to remember. And what I've shown you in this column is apnea severity classified into several groups. Normally 5 or less, so these two groups, is considered normal. Remember, I defined normal for you. The apnea-hypopnea index being 5 or less is considered normal. 5 to 15 is considered mild. 15 to 30 is moderate sleep apnea. And 30 or more events per hour is considered severe sleep apnea. And what I'm showing you here is the odds of having prevalent hypertension. So this is a cross-sectional analysis as a function of sleep apnea severity. What these odds represent is adjusted odds for having prevalent hypertension after accounting for factors such as age, which is an important confounder of interest, adjusting and considering gender, ethnicity, body mass index, neck circumference to account for central obesity, waist to hip ratio to account for central obesity. Most of you know that these are indeed, or at least some of these are indeed, risk factors for hypertension, and we want to look at independent effects. So we've statistically accounted for these things, trying to now assess the independent relationship between sleep apnea severity and prevalent hypertension. And what you see here is that when you are 30 events per hour or more, i.e. you have moderate to severe sleep apnea, the odds of having prevalent hypertension is 1.37, or 37% more likely. for having prevalent hypertension. There is a dose-response relationship, and it sort of really takes off after you sort of start looking at the mild to moderate and moderate to severe apnea. So this is a very large effort showing for the first time in a community-based study that sleep apnea is associated. I want to underline that word, associated. I have said nothing about causation. Correlation, association does not equal causation. That's very important for me to emphasize that. So this is a correlation. What about prevalent cardiovascular disease? Here again, if you take the apnea-hypopnea index and you break it down into quartiles, and you see the fourth quartile, these are basically 4 groups. Take the entire cohort and break into 4 equal groups, and the fourth group really has very mild to moderate disease. The cut point is very low, and what you find is that even individuals that are in this group with a very low threshold of apnea severity, you find that the odds or prevalent odds for having cardiovascular disease is 1.34, accounting for a number of different confounders that are well associated with cardiovascular disease. So this says that the odds are about 1.30 for these folks that have moderate to severe disease for prevalent cardiovascular outcome. Again, this is correlation and nothing about causation. This does not say that sleep apnea leads to cardiovascular disease. It's purely a cross-sectional analysis. Heart failure, very impressive relationship. When you look at the severity of sleep apnea and the odds of a prevalent heart failure, significantly higher, almost a 200% increase in prevalent odds for having heart failure for those that have moderate to severe sleep apnea, accounting for a variety of different confounders. Now again, this is data that we published almost a decade ago from the entire study. Now what about incident? What happens if you take sleep apnea today and completely neglect it? By the way, that's what's commonly done today. Most people don't think about sleep apnea. So I'm here to hopefully raise awareness. So these are data from the Sleeper Health study that look at incident. For the analysis of this paper, all those people that had hypertension at baseline were excluded. So no hypertension at baseline. Now follow people over time and look at whether sleep apnea leads to or is associated with development of incident hypertension. And the results of the study show that indeed that's the case. What the analysis did is that it broke it down in 2 groups. It broke it down at the median of the body mass index, which is 27.3 for this cohort. And when you look at individuals that are below this threshold of 27.3, just as a curiosity, that was the old definition, by the way, of obesity before it moved down to 25, or being overweight, sorry. 27 point something was the definition of being overweight. So if you look at this threshold, which is the median for the cohort, and you look at how the apnea-hypopnea index or disease severity of sleep apnea is correlated with the development of hypertension in those that were normotensive at baseline, we find that a moderate to severe sleep apnea is associated with development of incident hypertension with an odds ratio of about 2.7. So there's about a 200% increase in the development of hypertension if you have a sleep apnea at baseline and are normotensive. What's intriguing is that when you look at the other side, individuals that are overweight or obese, you do not see an association for any degree of apnea severity. This does not mean that in overweight individuals, apnea has no relevance. What this means is that in obese individuals, the effects of obesity are so overwhelming that to tease out the effects of apnea are very difficult. So I always see people misinterpret things, oh, it's only relevant in individuals. Well, that's not true. I just believe that this data suggests that there is an overpowering effect of obesity, and that really drives everything, particularly with regards to incident hypertension in this older cohort. Now, it turns out, if you look back a decade ago, something similar was published by the Wisconsin Sleep Cohort Study. In 2000, Terry Young and her group with Paul Peppard published this paper. We're looking at incident hypertension in their cohort. This is the Wisconsin Sleep Cohort, which was a cohort of 30 to 60-year-old individuals that were working in the Wisconsin area. And they followed these people over a 10 to 15-year period. And what they found is that if you look at the apnea-hypopnea index, again, this is no apnea, mild apnea, moderate apnea. As you go down the disease spectrum or disease getting worse, you find an increased odds ratio for developing incident hypertension. For developing hypertension, if there's no hypertension at baseline, and the odds ratio is about threefold. So this again confirms the data from the Sleep Health study and numerous other studies that there is in fact a relationship between untreated sleep apnea and the development of hypertension longitudinally. This is that first step that one takes towards proving causality, that there is in fact A leading to B and not necessarily an association, which is just hard to jump to causation. Now, recently another study published in JAMA came out, and what they did here is they followed about 1,900 subjects without hypertension. And this is a sleep center sample in Spain, and they looked at individuals from 1994 to 2000. These people did not have hypertension, and they asked, who develops hypertension, and what is it that about their characteristics with regard to sleep apnea severity that predicts the development of hypertension? Now, the next slide is a bit complicated, this one and the one after, but I'll go through it. What they've shown here is the incidence or the development of hypertension in those with obstructive sleep apnea as a function of disease severity. Without apnea, mild, moderate, and severe. And what you can see is that there's a beautiful dose-response relationship. Severe apneics are much faster with regards to development of hypertension. The incidence is higher in severe apnea, less in moderate, lower in mild, and not as high in those without sleep apnea. So there is, in fact, a relationship between apnea at baseline and the development of hypertension. They quantified these things. They quantified these curves, and the next slide is a bit complicated, but I'll go through with it. Well, they quantified this in these statistical models, and what they're showing you are what are called Cox proportional hazards model for the development of hypertension in those with sleep apnea. What they have done here is they've said, okay, we know individuals that don't have sleep apnea, they consider those as controls. And they looked at groups that were treated with CPAP, they were non-adherent to CPAP therapy, those that declined CPAP, or those were ineligible for CPAP. And what they have done across these different groups is to look at different statistical models. So each line here is a different statistical model comparing these four groups to the control group. And I want to draw your attention to the last line where they adjusted for things such as baseline blood pressure, body mass index, change in body mass index. And what they find is as follows. If you are treated with CPAP, your risk for developing hypertension is no different than the control group. If you are not adherent to CPAP, if you're not using your CPAP, you have 78% higher likelihood of developing hypertension. If you decline CPAP therapy, you're about twofold at risk for developing hypertension, and if you're ineligible, again, about a 1.33. So again, what they're showing you is that there seems to be a data supporting a causal relationship between obstructive sleep apnea and the development of hypertension, and potentially treatment with CPAP therapy can attenuate that risk for the development of high blood pressure. And that's the question, really, isn't it, for us? Does treatment of this disease mitigate the risk for hypertension? Well, it turns out there are numerous clinical trials over the last decade or so, and they're summarized in this meta-analysis published 3 to 4 years ago. And I just took one meta-analysis. And what you see is across studies from 1996 all the way to about 2007 when this was published, what the studies show that when you look at systolic blood pressure, treatment of sleep apnea with CPAP lowers systolic blood pressure by about 2.5 millimeters of mercury. Diastolic blood pressure, a mean change of about 2 millimeters of mercury. Overall mean blood pressure, about 2.2. That difference, one would say, 2 millimeters of mercury is not significant, but that's incorrect. The true interpretation of these data that at a population level, dropping a population's blood pressure by 2 millimeters of mercury has significant impact with regards to stroke risk and cardiovascular risk. So this effect of CPAP is not negligible. It's quite significant and relevant from the standpoint of clinical care. The Spanish group that I mentioned did one more thing. They asked a very interesting question. It's one thing to consider sleep apnea in the sleepy individual. One of the cardinal manifestations of sleep apnea is people are sleepy. They asked the question, if you have sleep apnea and you're not sleepy, if you don't have some of those obvious clinical manifestations, does treating you matter? Does your blood pressure get better, even if you're asymptomatic? It seems as though presence of symptoms in individuals with sleep apnea seems to mark them at risk. So this study actually extended that question, saying in asymptomatic individuals. So what did they do? 14 teaching hospitals, 725 patients that had moderate to severe sleep apnea, about 20 events per hour, and a sleepiness score, the score called the Epworth Sleepiness Score, 10 or less. It's a threshold that we use in our field to say they're not sleeping. It's a subjective report. It has lots of limitations. But it asked a clinically relevant question. Does a clinician who sees someone who's not sleepy but has apnea, should they be treated? And the answer is shown here. Let me go through this. This is the intent to treat analysis slide. And what they found here is that when you look at CPAP treatment in these individuals versus the sham group or no treatment whatsoever, they find no significant difference. At least the p-value is 0.2, albeit that the survival curves are very somewhat different. You can see that there's separation, but it's not statistically significant. But when they broke it down by adherence, when they said if you used your CPAP more than 4 hours a night, that's a threshold that we use clinically, say you're adherent to therapy. If you use your CPAP more than 4 hours per night, sure enough, their likelihood, those folks that had used it that much, their likelihood for developing hypertension was less. So in fact, this is relevant from the standpoint of non-symptomatic individuals having sleep apnea. This suggests that you can really decrease incident disease, hypertension, cardiovascular disease, even in the absence of clinical symptoms. I think this is an important study. One can argue this is post hoc analysis. There's some problems with that, et cetera. But it's very, very important hypothesis generating for our sort of next steps. So hypertension or cardiovascular event incident disease rate in that sample for CPAP was 9, for the control group was 11. And they said, gee, the p-value just doesn't make it. The ratio is less. The odds of developing, or the incident density ratio of developing hypertension or cardiovascular event is less, but it's not statistically significant. But again, this is all intent to treat. If you look at those that adhere, I think there is an effect. So their overall conclusions in this paper were that in the absence of sleepiness, which is a very important hallmark for this disease, CPAP did not result in a reduction of incident of hypertension or cardiovascular events. But I think there is this issue of limited power, because that post hoc analysis is important and shows that it may be in those that use it. So what's the message that I'd love to have you take away? Well, sleep apnea at this point, I think there is no doubt, is a risk factor, independent risk factor for systemic hypertension, to the point that it's now made it to the guidelines. Sleep apnea is the #1 risk factor listed in the Joint National Committee guidelines for treatment of hypertension as a secondary cause, and it's #1 up there. It's associated with sleep apnea that's even resistant to drug therapy. And think about this. In your clinical practice, if you see folks on 2, 3, 4 antihypertensive drugs, think about sleep apnea. You'd be surprised how prevalent that is. In the hypertensives that have obstructive sleep apnea, therapy may actually reduce blood pressure. It's a very important point. What about heart disease and heart failure? Again, I'll take you back to the sleep heart health data. These are incident data. These are data asking, okay, if you do not have cardiovascular disease today, and we leave your sleep apnea untreated today, do you develop do you have a higher propensity for developing coronary artery disease or heart failure? And the answer seems to be yes. And I've summarized some of the work here. If you compare individuals with no apnea to moderate to severe apnea, the hazard ratio is about 1.68. Now, it's important to recognize that this effect of sleep apnea was most notable in men, less than 70. We did not see this effect in women, irrespective of their age. And why is that? The reason is because as you get older, I'm going to take a little sidebar here. By the way, one of the things I learned from epidemiology is as you get older, bad things start happening to you. That is the biggest lesson I learned from the sleep heart health study. Boy, I mean, things just sort of spiral. And so, in fact, that's well defined. In epidemiology, that's called competing risks. What's happening when you start going over 70, there's so many things happening that it's really difficult to tease out one little factor that you can say is related to with regards to an outcome. So I think that one of the reasons we're seeing this is that there is this concept of competing risk. There is a survival bias going on here. Men less than 70 show a substantial risk for developing incident cardiovascular disease. Women don't, because women seem to be protected from the standpoint of most diseases. And in this sample, we were not statistically powered. And we are now continuing to follow up. Even at this point, we got extended funding from Heart, Lung, Blood to make sure that we follow the women long enough. And sure enough, with the larger sample size, we are recreating some of the same effects that we're seeing in men in women also. One of the effects is mortality, which I'll come to. Anyway, bottom line here, sleep apnea seems to be related to incident cardiovascular disease. Now let me switch gears again. Well, what if you treat sleep apnea? Do you make the cardiovascular disease stuff go away? Do you decrease the risk? We don't have large clinical trials where some of us are working on those, but this is an interesting study published in the Lancet, and I'll walk you through it. There's a lot of stuff here, but it's very simple. Let me walk you through it. This is a clinical cohort which was used and compared to a general population, to a bunch of snorers. And when this clinical cohort, they had mild to moderate sleep apnea that was untreated. They also had untreated severe apnea. These people just refused to use CPAP. That's the bottom line. And then there was 372 folks that were treated with CPAP. And this entire group was followed for about 10 years. And they had numerous endpoints. They looked at fatal cardiovascular events, non-fatal cardiovascular events, et cetera. They looked at every possibility. It's a nice observational study to compare treatment effects to non-treatment effects. So what did they find? What they found was something very interesting. I'll use these colors to designate the different groups as they have. If you look at the group that's sleep apnea with treatment, this blue group, which is this blue survival curve here, and this outcome is fatal cardiovascular events, what you notice is the blue group is no different than the green control group. However, those people that have severe sleep apnea that are untreated had a higher risk of a fatal cardiovascular event. And this is observational. This is not an interventional clinical trial. One has to be cautious about interpretation. But I think it's interesting and hypothesis generating again. Then there's obviously selection bias. Those that don't treat their sleep apnea are going to be bad with regard to health habits in general. So that may explain part of this. But again, interesting observation made by the Spanish group. When you look at non-fatal cardiovascular events, again, substantially high survival curve, i.e. increased risk for a non-fatal cardiovascular outcomes. What's amazing is that when you look at the CPAP group, they're no different. They're no different than the mild folks, they're no different than the snorers, and there's no different than the control groups. These curves are virtually overlapping over the course of their 10-year follow-up. So again, treatment may be helpful with regards to mitigating some of the cardiovascular issues. Again, I'm skipping a decade's worth of work here that I think I can summarize by saying that there is now good evidence that there is a cross-sectional relationship between sleep apnea and prevalent coronary disease. We think that there may be an increased odds for developing coronary disease if you leave your sleep apnea untreated. And in people that have established heart disease, there may be an increased death rate if the sleep apnea is untreated. I didn't show you data for that, but there is good data for this. And then interestingly enough, the sleep heart health data also show that if you've got cardiovascular disease today, and then you follow these people over time, their likelihood of developing worsening sleep apnea is higher. So it's this vicious circle. Sleep apnea may lead to CVD. CVD may in fact sort of come back and may worsen sleep apnea severity. What about arrhythmias? Very important outcome and sudden death. I sort of collapse these two. What about arrhythmias? One of the most important arrhythmias that's got a lot of attention is atrial fibrillation. And there's a numerous set of mechanisms that have been postulated. Hypoxemia, sympathetic activations, all of the things that I talked to you about before have been postulated that can lead to atrial fibrillation. And obviously transmural pressure gradients. When these people collapse their airway, there's a huge amount of pressure, transmural pressure on the atrium itself. And it could put additional stretch on it, make it a little bigger, and then maybe predisposed to atrial fibrillation. So lots of proposed mechanisms. These are data from the Mayo Clinic. These data, about almost 10 years old now, show that if you look at patients that have atrial fibrillation that come to a cardiology clinic, if you look at the prevalence of sleep apnea, it's about 50%. So 1 out of 2 folks that come to a cardiology clinic with AFib will have sleep apnea. But when you go to a general cardiology clinic, in the absence of AFib, the prevalence is much lower. This doesn't say that sleep apnea is going to lead to atrial fibrillation. It's a pure prevalence cross-sectional analysis. Data from, again, a Mayo group. Interesting finding. They went on and said, okay, let's look at atrial fibrillation and recurrence after cardioversion. If you've got a patient with atrial fibrillation, you cardiovert them to sinus rhythm. Who has recurrence of atrial fibrillation? Well, the people that are untreated for sleep apnea have the highest recurrence. People that are treated with sleep apnea have the same recurrence as those with atrial fibrillation and no sleep apnea. So it seems to point that if you've got AFib and you've got sleep apnea, there may be some benefit in getting you treated for sleep apnea to avoid the recurrence of atrial fibrillation. What about incidence? If you've got AFib and you don't have if you have OSA, who's more likely to develop atrial fibrillation? And obviously individuals that have obstructive sleep apnea have a higher likelihood of developing atrial fibrillation compared to those that don't have it over a course of about 12 to 14 years. Interestingly enough, the incidence of atrial fibrillation is a function of disease severity, mild, moderate, and severe sleep apnea. And these relationships seem to be related most likely to hypoxemia. Hypoxemia during sleep explains the increase in atrial fibrillation in individuals that have moderate to severe obstructive sleep apnea. So interesting findings with regard to the relationship between atrial fibrillation and sleep apnea. Some centers, not ours, but we're trying to make this happen. Some centers have moved towards getting a sleep study on pretty much everybody who's going to get cardioverted to make sure that their cardioversion, whether it's chemical or electrical, is efficacious and they don't miss sleep apnea that's untreated. So what can I say about AFib? I think there is good data that there is an association between sleep apnea and prevalent atrial fibrillation. I didn't show you information on ventricular arrhythmias, but pretty much every ventricular arrhythmia you can imagine, non-sustained VT, paroxysmal VT, ectopics, multifocal PVCs, all of them seem to be higher in individuals with sleep apnea. Again, maybe related to hypoxemia. So there's good observational data suggesting that untreated sleep apnea increases the risk of incident atrial fibrillation and recurrent atrial fibrillation following cardioversion. Now, there are ongoing clinical trials that are trying to prove in a randomized fashion that if you treat half, don't treat the other half, what happens to recurrence of AFib after cardioversion? Varen Summers at Mayo is taking on that task. What about sudden death? Just out of curiosity, where do people usually die with regards to the circadian rhythmicities? Do people know where is the peak death rate over a 24-hour period? Is it 12 o'clock in the afternoon, 6 o'clock in the morning, 6 o'clock in the evening? Any ideas? 6 o'clock where? Morning, good, I'm glad. So it turns out that's exactly correct. If you look at, this is again data from the Mayo Group published in the New England Journal, if you look at people that do not have sleep apnea and are the general population, the peak death rate is going to be between 6 a.m. and 12 a.m. So peak death rate is right about here, sort of that light blue and the sort of lighter blue. But if you look at people with sleep apnea, this the white bars, you can see that they have the highest death rate between midnight and 6 a.m. Interesting, one inference is, oh, gee, they're having sudden cardiac death during the period of sleep, which again, you're making a huge leap to go to causation, but it's an interesting observation that sudden cardiac death seems to be common in these people, and they seem to die most likely between midnight and 6 a.m. And the risk ratio is about threefold. So the likelihood of a sleep apnea patient dying between midnight and 6 a.m. is threefold. Whereas if you don't have sleep apnea, the risk of dying is about twofold, as most of you said, between 6 a.m. and noon, right? That's when the general population not at risk for sleep apnea has the highest risk. So just a quick, observational issue about sudden death. There seems to be a peak sudden death from cardiac causes during sleeping hours. It's not obviously solid data on causation, but it's interesting in an observational sense. In contrast, those without apnea have a nadir in the probability of sudden death during that period of sleep. What about stroke? What do we know about sleep apnea and stroke today? Well, I can tell you, the Sleep Art Health study again has shown, and numerous other studies, that there's a risk of stroke in men. And I'm going to show you the men and women analysis separately because, again, men are indeed from Mars and women are from a better planet, I think. I'm not sure if it's Venus. The risk for sleep apnea in men, the risk of stroke in men due to sleep apnea is the highest. They have a threefold risk if you have moderate to severe sleep apnea. What's done here is that the group has been broken down into 4 quartiles as a function of the obstructive apnea hypopnea index. And those in the largest quartile seem to have almost a threefold risk for having stroke 10 years later after the initial diagnosis. Accounting for all other things such as body mass index, blood pressure, diabetes, etc., they have a highest risk. A similar effect was observed in women, not as strong, but not statistically significant. So we don't see this in women, primarily, again, because not enough women in our study, I didn't put the numbers of strokes here, not enough women in our study had strokes for us to do good epidemiological analyses from the standpoint of stroke. And again, the new data that's coming across in the last 12 months will help us close this gap on whether women, in fact, are also at risk from sleep apnea. So just a quick word on sleep apnea, that is associated with incident stroke, in men particularly, and we are limited by statistical power with regards to stroke in women. So conclusions that I would like to sort of summarize from the standpoint of cardiovascular implications. I think we're pretty solid ground today. 10 years ago, when I started my postdoctoral fellowship, I don't think this was the case. I think we are convinced at this point that sleep apnea is associated with prevalent and incident hypertension, prevalent and incident heart disease and heart failure, arrhythmias and sudden death. The issue of causality remains to be determined here, and treatment effects of sleep apnea to be determined here, and possibly also here, and obviously stroke. So the effects of treatment are to be defined, but epidemiologically, there's good data on risk at this point, and obviously stroke. Now, let me just end for the last 5 to 10 minutes on metabolic implications. I hate to do this, a topic of my research interest, something that I've spent the last decade studying. I'll give it 10 minutes, or maybe even less. Just to review with you, what do we mean by diabetes? I think most of you know this, or metabolic abnormalities. What I've done here is plotted for you on the y-axis fasting glucose. All of you know that the American Diabetes Association considers a fasting glucose of less than 100 normal. 126 or above is considered diabetic, and the middle stuff is called impaired fasting glucose. Now, if you were to do a glucose tolerance test, I know most of us don't do them, but we can do it in a research setting. We can obviously do it in a gestational diabetes assessment setting. When we do a glucose tolerance test, the thresholds set by the American Diabetes Association are 140 milligrams per deciliter and 200. And what I've done is graphically shown you what are all possibilities that can occur. You can be normal, you can be impaired fasting, you could be impaired glucose tolerant, but normal fasting. You could be both, or you could be diabetic in this red zone. Each of these categories are thought to be a risk factor for developing diabetes, and each of these 3 categories and diabetes is thought to be a risk factor for cardiovascular disease. So being in this green zone is probably the best thing for all of us. Being in any of these non-green zones is thought to be an important marker for cardiovascular disease. Diabetes. I think you know this, but I'm very impressed every time I show this. This is a heat map of diabetes prevalence generated by the International Diabetes Federation in 2010. The United States has a prevalence roughly in the 9 to 12% across. All of North America is pretty much there. The Saudis, about 12%. The Indians, pretty high because we're just a big population. The Chinese also, lots of stuff. Now, look what happens to 2030, right? I'm going to go back and forth. Now, diabetes, the United States will go very, very high. All these countries will start catching up. Today, just today, it is estimated that 300 million people around the world have established diabetes. Let me say that again, 300 million people. In the United States, there are about 300 million people. So imagine the entire country with diabetes. That's what exists in 2010. It is estimated that when you look at 2030, that 300 million is going to be at least 600 million, even more. We're going to see about 1 billion people that are intolerant glucose or impaired fasting or diabetic. And in fact, it's that for that very reason, the UN has recognized diabetes as an important disease. The UN doesn't recognize diseases except 2, HIV and tuberculosis, because those are 2 diseases that threaten world health. Diabetes in 2006 was the 3rd disease recognized by the UN as an important threat to world health. And this is going to create a substantial problem. There are obviously many factors that lead to this. One is this one, right? I mean, we spent 2.5 million years going from there to there, and it took us 50 years to do this stuff, right? This is clearly a driver. But the other driver that some of the sleep folks are thinking about is that, is there something else going on beyond this? Sleep may be an important component that may have made this transition to having metabolic disturbance. So let me just give you 3 topics that I just want to quickly review with you. What does sleep apnea do to insulin resistance, glucose intolerance? What does sleep apnea do to insulin secretion? And I'll explain insulin secretion in a minute. What are the effects of hypoxia and fragmentation on glucose? And does CPAP make these things better? So quick tour about this stuff. There are numerous articles, some written by us, some written by the Chicago group, on the relationship between sleep apnea and diabetes. About 20 years of research has gone into this area. It took off in 2002, but there are articles that date back to 1993. And we summarized those articles in 2009. Every 3 years, I get a little period of boredom where I basically want to summarize all the literature. I think it's about that time again. I gotta go back and summarize. This is a 2009 summary. And what we found was 23 studies that we summarized. In those 23 studies that examined the relationship between sleep apnea and insulin resistance, 17 out of those 23 concluded that there's an independent relationship. Independent of what? Independent of age and obesity, the biggest bugaboo in this relationship. that there's an independent relationship between OSA and insulin resistance. 17 out of 23 studies concluded that. When you look at studies on sleep apnea, metabolic syndrome, and type 2 diabetes, that's a typo, sorry, my fault. 23 out of the 25 studies that we can find showed an independent association between sleep apnea, diabetes, and metabolic syndrome. Independent of what again? Obesity and other risk factors such as age, etc. Let me show you just one data slide because it's worthwhile. In the Sleep Art Health study, what we found is that if you look at apnea severity, mild, moderate, and severe, you see an increased prevalence of impaired fasting glucose, and diabetic fasting glucose. What this says is that those people that have moderate to severe sleep apnea have the highest prevalence of diabetes and highest prevalence of being impaired. And there seems to be a dose-response relationship. The worse you are, the higher the prevalence. Nothing about causation, purely correlation. There are obviously confounders. You have to worry about obesity, you have to worry about age. So we did that. We looked at statistical models that would help us correlate the severity of sleep apnea, which is defined here as no apnea, mild, moderate to severe, and the prevalence of having an abnormal fasting glucose in about 2,000 folks. And we found that if you have moderate to severe sleep apnea, the odds of having an abnormal glucose is 1.46, or 46% higher likelihood for having an abnormal fasting glucose. What was impressive about this analysis in a community cohort was hypoxemia. The more hypoxemic you were, these are quartiles, the higher odds ratio of almost twofold, the higher likelihood of you having an abnormal fasting glucose, independent of body mass index, waist circumference, smoking, age. All of those factors accounting for, there's a relationship. When you look at glucose intolerance, mild, moderate, severe, higher prevalence, and a dose-response relationship between glucose intolerance and mild and moderate sleep apnea severity. No matter how you cut this, these people seem to have a higher abnormality, a greater propensity for abnormal glucoses. Insulin resistance is another factor to think about. Insulin resistance is defined by the simple metric. You take your fasting insulin and you multiply by fasting glucose. Very simple measure, used in epidemiological study. The higher this is, the worse you are. People with mild to moderate sleep apnea or moderate to severe sleep apnea have the highest HOMA levels, homeostasis model assessment index. Accrued index of insulin resistance was the highest, independent of all risk factors. They're insulin resistant, they're glucose intolerant, and they're more likely to be diabetic. And it doesn't end there. If you look at sleep apnea severity on the x-axis, this is non-existent, not even mild apnea, mild to moderate, moderate to severe, and so forth. There is a decrease in HDL cholesterol in men and women. There's a nice dose-response relationship between severity of sleep apnea and HDLs. You look at triglycerides, they go up with apnea severity. And again, the LDL, HDL, all of them trends are exactly the way you think they are. A quick word about insulin secretion. Why is insulin secretion important? You cannot develop diabetes. You will not develop diabetes if you do not have impaired insulin secretion. You can be insulin resistant, but to develop diabetes, you have to have impaired insulin secretion. Your beta cell has to stop working or be ineffectual in some ways for a given level of insulin resistance for you to develop type 2 diabetes. How do we measure insulin secretion? Very easy. You give IV glucose, your insulin levels go up. You give IV glucose to a diabetic, their insulin levels will not go up. In fact, that's the definition of type 2 diabetes. The area under this curve is called the acute insulin response to glucose. How much insulin did you make when I checked? Some of you have had some pastries. Your insulin levels were a little higher after that pastry, and they've slowly come down. That's what we're measuring with the bolus of a glucose load. If you become insulin resistant, you'll make more insulin. So if I keep you sedentary, you'll make more insulin. And that's what this curve shows. As you get older, you'll move down this curve. You'll become more insulin resistant. As you gain weight, you'll go down this curve, but you'll make more insulin. This hyperbolic relationship is well established. When you fall off this curve, it's when you develop diabetes. These two things are very important. You can be insulin resistant, like an apneic is, but if they do not decompensate on secretion, that's okay. They will not develop diabetes. So we did a study looking at insulin secretion, 118 apneics and controls. By the way, it's impossible to find an apneic with no medical conditions, but we found them. It's impossible. I sat there for 5 years every morning going through sleep clinic. It was the most torturous thing that I've done to myself, and I will never do that again. They were young, they were relatively overweight. What did we find? We did glucose tolerances on them. We gave them glucose, it goes up, comes back down. That's the beautiful AIRG, acute insulin response, that area under this curve. That's how much insulin they made, right? Now look at what happens to an apneic. Nothing. Absolutely nothing. And that was the trend. Apneics seem not to make insulin. For whatever reason, I think we know the reason now. Insulin sensitivity decreases, as we knew before, with severe apnea. Now, if I make you insulin resistant right now, you will make more insulin. You will compensate. These folks did not compensate. What should have happened is, as you got more apnea, you should have made more insulin. They didn't. They're falling off. They're decreasing with regards to insulin secretion. So there's an impairment in insulin secretion in these folks, and that seems to be independent of body fat. They're not only insulin resistant, they have impaired insulin secretion for a given level of insulin. They've got the double hit that these guys should not get. Why? Is it hypoxia? Is it arousal? What is it? We don't know, but we think we've started teasing this apart. We did a quick study, 2 studies on hypoxia and fragmentation. I'll go through them with you very quickly because of time. I think I'm running out. What we did is as follows. I wanted to ask the question, can we cause this stuff? I'd love to give 100 people apnea and 100 people no apnea and follow them for 10 years. The ethics committee just told me not to do that. So I came up with another idea. I said, okay, why don't we make normal people apneic for a day? Will you let us do that? And they were okay with that. So what we did is we actually took normal healthy subjects. We exposed them to hypoxia for 5 hours. And in another study, we took normal healthy graduate students, and we did what you all do with the beeper. We rang the beeper again throughout the whole night. We fragmented their sleep about 60 times an hour. So 1 every minute we would ring the beeper tone. How did we create? Yeah, I always get, the CIA got interested in that study because it doesn't violate Geneva Conventions because you preserve the sleep. And so a very interesting story for those on it. Hypoxia was created manually with 2 tanks. One was air, the other one was 5% oxygen. The fellow was awake, watching television, CPAP mask. We sat out there, turning the dial back and forth. You know, we did a randomized study. One day made hypoxic, and then another day we made them normoxic, you know, basically the oxygen all day or air. And we created this. You created a saturation. This is about 30 events per hour for the entire night, entire day. The FiO2, as you can see, goes up and down from 21 to 5. Their saturations go up and down. There was no significant change in the end-tidal CO2. And for those that are nearby, the electrocardiogram speeds up. Obviously, because they're hypoxic, they're sympathetically driven. Guess what happens? Their insulin sensitivity decreased. We can make you insulin resistant within 5 hours of hypoxia. And that was known. The military knew that. When they would do these missions to high altitude, and when they would take them up to extremely high altitudes, these folks had high epinephrine levels, high cortisol, and they were insulin resistant. So we proved that again. What's interesting is they didn't make more insulin. This bar with hypoxia is supposed to be up here to compensate. They didn't do it. Hypoxia seems to impair the beta cell. So there was a decrease in insulin sensitivity. We saw an increase in sympathetic activity. We didn't see a change in cortisol. Now we've gone further and tested this hypothesis in the animal. We have numerous findings on why it does it. What about fragmentation? What happens when you actually fragment people's sleep over the course of the night? And we did that for 2 nights. By the way, torture. Don't ever do this to anybody. I was my first subject, by the way. How do you wake people up in the middle of the night? Do you all know that? You can ring a tone, but you attenuate. For those that don't know, deaf people use buzzers to wake themselves up. We put 4 buzzers in the bed. My graduate student taught me this one. He just wouldn't wake up in the morning. He would have phase delay. So he used mechanical vibration. So we put those in there. And what we would do is we would, again and again, stimulate them. You know, we would ring a tone. If they didn't wake up, we would run a buzzer. If they didn't wake up, we ran 2 buzzers. And oh, it's torture. Arousal throughout the whole night, but they would sleep through. Insulin sensitivity decreased with fragmentation. Insulin secretion increased. Hypoxia wasn't present. So when the individual's not hypoxic, you can respond to insulin resistance. So fragmentation of sleep, your beeper, for those that trained with me back in the last decade when we had, you know, Q3 call, we were probably insulin resistant back then. Increase in sympathetic activity, higher cortisol levels. So I sum all the metabolic stuff up this way. It's a sort of working diagram. Apnea does 2 things to you that are bad for us. We think that sympathetic activation is bad, leads to insulin resistance, leads to type 2 diabetes. We have now data that says hypoxia impairs beta cell. The beta cell dies in a petri dish when made hypoxic. much more quickly than any other cell line. It's very sensitive to hypoxia. It does not have superoxide dismutase, which is necessary for redox reactions. It cannot handle intermittent hypoxia. Treatment with CPAP, one last slide. I'm going to skip this one. If you take a diabetic and you give them CPAP, believe it or not, you can bring the hemoglobin A1C down. Old study, uncontrolled, lots of issues, and that's why we undertook the study that ResMed is sponsoring. About 300 folks internationally did this in a randomized fashion, and those results are pending at this point. So interesting information about improving glycemic control in diabetics with treatment of sleep apnea, again, uncontrolled. So we summarized the study, and we found that the glass was half full or half empty. 7 out of 19 studies published up to 2009 show that there is a favorable effect. The rest are equivocal. Last slide on a randomized clinical trial published in the New England Journal for metabolic syndrome. These folks gave CPAP to those with metabolic syndrome and sleep apnea. What did they find? You can decrease blood pressure, improve cholesterol, improve LDL, improve triglycerides, and decrease the prevalence of metabolic syndrome. It makes it better, we think, in these studies. So, let me conclude by saying, I know, Ali, you want to take a nap? Now, that's the great thing about being a sleep guy. You know, if you guys fall asleep during our talks, we are perfectly appreciated. We didn't educate you, clearly, but at least we let you go into a state that was refreshing. Thank you very much for your time.